Hey everybody, welcome back. This week we're going to be covering methods of assessment and diverse populations. Now, one thing you'll realize as we go through this is that in terms of diversity, we only have one slide at the end, and there's kind of an intentional reason for this, and it's not because I don't think it's important and that I want to brush over it and not address it accurately. The reason for brushing it over it is, for one, for those of you that are in the class, we're going to be talking about this in class. We're going to have more of a discussion. Number two is that instead of spending 1 week on it and then forgetting about it throughout the rest of the weeks, what we're going to do is cover it lightly here in kind of a 30,000 foot view. And then we're going to talk about it more specifically in terms of how it comes up later. In the syllabus, you know that the second half of the class, we're going to be talking about clinical assessment, personality assessment, intelligence assessment, career assessment, assessment in educational settings in terms of achievement, aptitude assessment. There's going to be a lot of stuff, right? So what we want to do is, in all of those different unique ways, especially specific to each of you and where you think you're going to be working, we want to bring up this question of diversity and how does the test meet the unique needs of the people that you're going to be assessing, okay? More specifically, how might it adversely affect the people you're going to be assessing? So here's just a simple example, and we'll go into more detail later on. But if I am assessing, let's say, a Mexican American who speaks good English, but it's not their first language, they go in and take a test in English, and there are some words that they don't quite understand, or they just aren't familiar with the definitions of them or something like that. That is not to say that that person has less intellectual potential, but they may not score quite as well on the assessment. So are they not intelligent? Does their brain not have the capacity to do what it's supposed to do? Or do they just not have the smarts? It's a tough question, right? But it probably doesn't mean they're not smart. Another example, if you have an entire population of, slaves who are systematically oppressed for many decades and then still haven't made quite the academic gains because of the systematic disadvantages, are those people going to perform as well on intelligence tests? Does that mean they're dumb, or does it mean they've been failed by the education system? So is it an intelligence issue or a systematic political issue? That's one of those things that, is a debate that we can have in classes and whatever. And we can talk more about that stuff specifically. The overall main point is that in all these various ways of assessing, we want to make sure we're using the right tool to get the right kind of information. If we're not doing that, it's an issue of ethics. It's an issue of diversity concerns in a multicultural world. That's what we'll talk about throughout the course, not just in one class. So that's my rationale. If you don't like that rationale, tell me about it and we'll talk about it. But that's kind of what I've chosen to do for this one. So let's jump into it. We talked about some of these things last week, so we're going to kind of just briefly overview them mostly right now. And some of these we'll get into a little more specifically too, but I don't want to be redundant. But in terms of the methods of assessment, remember the purpose of assessment is gathering accurate information. We do these interviews, and interviews are relatively simple things to understand, and yet they also are very complicated and based on a lot more than just a conversation between two people, right? I have this pet peeve that I like to complain about, which isn't really a complaint, but in my rehab life, job interviews are one of those things that most of us are wildly uncomfortable with because we don't practice them very often. They ask us to talk about things that are probably uncomfortable to us. And even from an interviewer's perspective, it can be hard to know in 1/2 hour, 45-minute session whether this person is the right fit for my organization. To me, it feels a little bit like speed dating. You have to make these big decisions. You're kind of betting on somebody being a good fit to do your job within a small amount of time, right? Or saying like, this person is worthy of my future time by this one speed dating session that we had together, whatever. So in order to get really good at interviewing, but counseling specifically, the people who are the best at it are those that can very quickly and accurately gather the right kind of information and the majority of it, while also building rapport, providing a therapeutic experience for people by expressing empathy and compassion for people but also so giving out what they can to meet a person's needs, but also getting back what they need. And they do that with just this deftness and sort of a grace that when you see it happen, you're like, holy crap, that person is really good and they know what they're doing, and they build so much confidence in the therapeutic process. And that's what we're working towards in terms of what it looks like on the outside. It seems like a relatively simple thing, but it comes from years of practice. And that's what we're going to kind of discuss today and start the practicing process. Testing, we talked about last week too. We're kind of using the terms testing and assessment synonymously for the most part. But testing are like the actual physical scales or instruments that we're going to be using. Interviewing are like the questions that we've built in through the practice process to be intuitive for us. And then observations, we talked about that last week. We're going to talk about it a little bit more in a little bit. So we'll kind of leave that one for a second. One of the things that I've observed is that counselors often get practiced at doing an interview and often stop there. They don't tend to love formalized assessments for various reasons, many of which we talked about last week. They cost money. They take time to administer. We can't often get reimbursed in the same way, depending on how you're getting reimbursed. We sometimes feel undertrained for them, or we feel confused about what we know in terms of how we can administer them and interpret them. We get nervous about getting in trouble because tests show up in law and in statute, which we talked about last week. And we just say, well, we'll just avoid all of the potential to make a mistake and get in trouble. So I'm just not going to do anything. So for those reasons, and probably more, people engage in interviews but avoid the testing process. There are these two kinds of testing, though. There's the informal and formal standardized, which we, again, will go into a little bit more, and we'll practice those throughout the semester. But as you think about your interaction with assessment and testing, think about these various different methods of doing it, which ones you're comfortable with, which ones you aren't comfortable with, and maybe more importantly, what are the reasons you're not comfortable? It's one thing to say, I'm not qualified and I can't do that, versus I'm not sure if I'm qualified and I'm just going to avoid it because it makes me uncomfortable to think about it. So that's not a great reason, because it does a disservice to your professional potential and also the client's services that they get, what they can know about themselves and about you. So we'll leave that there for now. Okay. Sorry, I had to click away a thing at on my screen. Something popped up. The interview. There is the initial interview, and then, as we said, assessment is a dynamic process. The interview continues throughout the therapeutic process. According to the systematic process of reimbursement and billing and all kinds of that stuff, the interview typically is the first session, and the assessment happens during that session. And yet we're constantly adding more information, right? And that more information builds more context. The context just increasingly expands in terms of, like, this person has this clinical condition of anxiety or underperformance in math or whatever the thing is. And yet we learn, oh, it's because they didn't eat breakfast yesterday, or it's because this person, their parents are going through a divorce, or it's because of XYZ reason. They had a car accident and they had a concussion. Now they've lost their memory, and just all kinds of reasons that help explain the context. So that initial interview and ongoing interview provides that kind of context. How do you decide whether a test is appropriate or which ones you need? Well, that's a complicated answer too. Part of the way you decide is by, remember when I said a few minutes ago that the best assessment people, they just have a sense of what kind of information is important. And here's an example of what that might look like. Client comes in and they say, let's use a school example here, like at a university. For those of you that are going into practicum, you'll meet university students in our clinic, and they'll come in and they'll say, I'm just stressed out, and I don't, I'm like not going to class, and I'm not doing very well, and I just broke up with my boyfriend, and it's all so much. So you say, well, based on what I know, let's maybe find out if there's some symptoms of depression and anxiety. Maybe you're not going to class because you're motivated, a symptom of depression. Maybe you're worried about your future, a symptom of anxiety, right? So you say, I'm going to maybe test for anxiety or depression. Okay. You could use a formal tool for that. You could just ask some more questions based on what you know about the symptomology of either condition. The other thing you might do is you might say, well, tell me about your rest of your life. Do you have friends? Do you have family? Do they support you? Do you go home on weekends? And you go into all these things based on what you know about college student experiences and what some of the stressors are. Okay. So do I need a test for that? Well, you are informally testing for college age student stressors, typical college age student stressors. In one case, you use a formal testing tool. In the other case, you use your experience to assess information that is relevant to them. So how do you decide what is appropriate? You just kind of learn through experience what tools I have available. And if I need to make a diagnosis, then I need to use this tool. If I don't need to make a diagnosis, I still need to find out what's going on. And based on what I know from experience about college students and their stressors, these are the questions I'm going to ask. If you don't know what questions to ask, then you go get supervision and you ask other knowledgeable people and you read research and you read books and you do all kinds of other activities to learn more. So that is generally speaking the process of how you decide. There's another big way of how you decide, and it's that you don't have a decision to make. If you work at a big agency or you work at a hospital and they say, well, we have to report data for a grant or we're doing a research project and you have to gather this kind of information, specifically those of you who are working in the the addictions world. If you're doing substance abuse counseling or addiction or working in AODA for whatever reason, oftentimes you are dictated or demanded to do certain kinds of assessment to gather certain kinds of information, and it doesn't feel like a choice. And yet, it basically still is in many ways. You have to come up with the data, and how you collect it sometimes is dictated, but there's also this other part of the process of how you choose how you're going to do that too. So that warrants more discussion another way later, but we'll just leave it there for now. You may have some information in advance and can weave in a test. In other words, remember when we talked last week about getting records? You have records that get dumped on your desk and you have all this advanced information. And if you know that, then you can say, well, they were screened for depression before and they were given a diagnosis of depression. Let's test again just to make sure, something like that. Oftentimes what this looks like mostly in an interview is you sit down with the person, they've made an appointment, they show up on your calendar, you've never met them, you know nothing about them. And you say, okay, go through informed consent. You say, okay, tell me about what's going on. And they say, let's just make up something on the spot here. Life is kind of hard. I just lost my job and I had to move out of my house because I was getting a divorce. And so my parents live in the next state over. I'm going to move over with them, but I can't quite yet because custody stuff. And so I'm just under a lot of stress and I just can't sleep and my stomach hurts all the time. And in your head as a counselor, you're thinking, somatic issues, lack of sleep, worry and concern. This sounds kind of like anxiety stuff, right? And so as a person starts to disclose their story or they're presenting concerns based on what you know of symptomology in DSM diagnosis or in other sort of life treatment issues based on your theoretical perspective, you might start developing a sense of, I have a tool for that. I have a question for that. I know which direction I need to go based on what information I'm getting. So you don't necessarily always have all of your assessments laid out in front of you when a client comes in for the first time. After you meet with them, you hear a little bit about them. You say, oh, okay, I need some help with this diagnostic process. So let me grab this tool and I'll use it for this purpose. Because there's a lot of conditions in the DSM. There's a lot of conditions in the human experience. And so you'll need to sort of have things at the ready within reason. You'll have time to develop this and you can always come back and ask them later too. but you have things at the ready to say, now that I know you a little bit, I can ask more questions or use these other tools. And now that I know more from that, we can ask even more questions, and we build and we build and we build. Okay. So we talked about structured interviews last week. The example I gave was if you're doing like intelligence testing, if you're using formalized tests, oftentimes there is a very structured process to it. We'll see some examples of that later, but that's really not what I want to spend most of our time on, because it's not what most counselors engage in terms of most of their work. When they do engage in it, again, oftentimes for the people that we have here in the classroom, what we're often looking at is people who work for agencies, who work for county departments, who are required to do certain kinds of assessments and gather a certain kind of information. It's most common that you'll have some sort of structured interview process. Most often I see this in terms of like addictions. You have to gather all this background information. And once you gather the background information, then you test for some basic mental health disorders. And then you do, a very structured interview form. That's kind of how it shows up most of the time. And what I hear a lot from people is like, okay, I have to gather all this information and it goes off somewhere, but then I don't really know what to do with it. I don't know how to use it in meaningful ways. That's the other part of the class that I want to talk about in classes and in discussions of, if you're having to do this information, gather this information, but you're not using it, is it meaningful? Is it purposeful? Well, it certainly helps the program it helps the agency maintain the program that you're working in by getting funding again. And that's important, right? So it's not completely useless. But how does it help you make good clinical decisions? That's the part where we'll learn to tease out some more information from just like demographics and histories and that kind of stuff. Semi-structured, we'll get some practice a little bit later on too. So I'm going to kind of leave that because it's kind of like a combination of the interview, which we've described, and the structured process, which we described. So just hold tight with that one. The unstructured process. This is kind of a misnomer because the way I've described basic interviewing is essentially unstructured. Someone comes in and you say, what's going on? Tell me about yourself. What brings you here? What brings us together today? However you start that, it's this open invitation to say anything you want to say, right? And yet we've talked about how it's not agendaless. It doesn't mean that I'm going in blind and just saying like, well, dump a bunch of information on me and I'm sure we'll figure out what to do with it. It's no, I know I'm learning about what information matters and what doesn't. Okay. So that happens through the process of really thoroughly understanding your theoretical perspective. If I come from a cognitive perspective, I might say, well, tell me what's on your mind. And they say, well, I'm having these thoughts of suicide. And you say, tell me about that. Sounds painful. What are the thoughts? What comes to mind? Just give me the picture. Like draw me the picture of what pops into your head and what's going on around you when you're experiencing that. Those kinds of things comes from a cognitive perspective, right? If I'm an existential therapist, I might ask questions about meaning, about where are you in life? What's going on in your life? What's your experience of the universe and your place in it? Like that kind of stuff. So it's guided by my theoretical perspective. It's guided by my referral sources in terms of what specific information I need. Oftentimes, if you're in private practice, you may not have a referral source. Someone comes in self-referred and they say, I just want to be happy. I just want to feel better. And then you have to decide the direction of counseling and what they want to get out of it, whether their goals are realistic or not, something like that. So it's not agendaless. It does have structure. It is a systematic process. And yet it feels like ambiguous and difficult and challenging. And so people think of it that way, but it really is not. It's really pretty amazing to me when I watch really experienced therapists and counselors work. I was just in a workshop last night, and people going into their first clinical experience, one of the things that was commented was when they were watching these role plays of faculty here kind of demonstrating what the clinical interview looks like from the very beginning, they were like, it just looks so comfortable. It looks like it doesn't even require any effort. And the effort is required. It just came from the dozens and dozens and hundreds, maybe thousands of clients that a person has seen to practice to get to the point where it looks effortless and agendaless, but it really is not. So anyway, okay, let's talk about some specific issues in testing. These are all kind of just randomly placed and they don't all relate to each other. So let's take them one by one. High stakes versus low stakes. If you were sitting there thinking to yourself, I'm really nervous about this testing stuff because last week Aaron talked about the laws and I don't want to get in trouble and I don't want to hurt anybody. And we have these regulatory processes to keep people safe. And I'm scared about the potential to hurt somebody. So I just won't want to engage in assessment. Well, the great majority of assessment that you're going to be doing is low stakes. Let me give you an example. Someone comes in and they say, I think I'm depressed. And I'm like, okay, well, how's your sleeping? And they're like, well, I sleep fine. And then I say, like, tell me about your sex life. And they're like, what does that have to do with anything? And I'm like, ooh, that was probably not a question that was relevant at the time, right? Like, mistake, probably didn't need to go there. I'm being dramatic, obviously. And they're like, yeah, that was weird, but let me get back to the story, right? There hasn't been a significant rupture in the relationship. They're not totally creeped out. Well, maybe they are creeped out. This is probably a bad example. But if there's not a rupture in the relationship, it hasn't caused any sort of harm to the person. They're still with it. They still want treatment. They're still working together with you, and you're still providing quality services. Nobody was really hurt in the process, and nothing was broken. Nothing in the relationship requires repair. Maybe a little bit, but okay, so I used a bad example. I should have picked a better one. But if you get the idea, like, we make mistakes and we're going to ask the wrong questions and we're going to ask them the wrong way, and it's going to make things uncomfortable and awkward. And we're going to do that because that's what practicing is all about. And yet it's low stakes because it doesn't really hurt anybody. It just sometimes is off mark, or it's not effective, or it doesn't help in the ways we really intend it to. Those are low stakes, right? The mistakes we make that aren't going to be life threatening. And yet there are testing or assessment situations in which are very high stakes. So picture this all on a spectrum: low stakes over here, high stakes over here. Swing the pendulum all the way over to this other side of the spectrum and think about a person comes in and says, I'm not looking for therapy. I'm looking for an evaluation on whether I qualify for a disability that I need to use for a Social Security application, which means I can't work. My doctor said I can't work, but I was denied Social Security. Can you help diagnose me or give me an evaluation of a diagnosis to see if I would qualify, that I can give that to then Social Security and hopefully get benefits so I can live? In other words, it kind of feels like either I have money or I don't. I get my basic needs met or I don't. It's not necessarily life or death, but it kind of feels like that. That's a little more of a high stakes situation, right? Another example is somebody just committed a crime and they're on trial for life in prison, and they have a psychologist come in and says, is this person insane? Are they mentally competent? And they ask all those questions. We're going to talk in this class about some of the same assessment tools that get used to determine defenses of insanity or mental capacity or competency, that kind of stuff. That's kind of like a life in prison and sometimes even the death penalty. And those are pretty high stakes situations, right? So there's all kinds of levels of risk and potential risk of outcome. And that's what we want to get good at, saying, where am I comfortable in terms of what assessments I can provide, and where am I not comfortable? Where am I competent, even if I am uncomfortable? Where can I do these things, and where do I really need to ethically be responsible and say, this is not my territory, I can't engage in that kind of activity? So that's something we need to be aware of. Standardized versus non-standardized, I've kind of already talked about that, and we'll do more discussion about that for sure throughout the class. Individual and group assessment, especially for those of you that are in educational settings like school counselors, you will likely do some kind of group assessment. If you run groups at your work, the evaluation of the group process, from establishing the group, sort of what is it like? I always forget how this goes. I had it memorized one time, but like norming, storming, performing, adjourning. There's those stages. I forget them off the top of my head, but um, if you are working in groups, you're assessing, is this group working on their own issues and supporting each other in the process, or are they jockeying for position of like who's got more trauma or who gets more attention from the group leader and like that kind of stuff. So you're constantly assessing in a group way. Another version of group assessment is if you have a bunch of kids in a classroom and you have to administer a test, you're going to use different procedures for how you administer that test, right? You're going to give group instructions. If somebody needs individualized instruction, you're going to need to find a person to help give that individualized instruction and give the standardized instructions to the rest of the group. And so there's just a different process in terms of group work versus individual work. Another concept that's I don't know how helpful it is for us to know in this context, but I'll explain it just very briefly. In terms of maximum performance or typical performance, trying to think of an example of where this would matter in our therapeutic work. Maybe something like a person comes in one day for counseling and you've been seeing them for a while, and you know that their typical performance is they can get up and get out of bed and they get ready for their morning routine, and then right before they get in their car to go to work, they have this pain in their stomach of like just kind of this anxiety pit of their stomach, feeling of like dread, and I don't want to go to work. Sometimes people call it the what is it, like the Sunday scaries. People get a lot of anxiety Sunday nights before the work week, or maybe it's before a big test or whatever, and that's like typical for that person. And then one day they came in and they say, I didn't go to work all last week. Last week was a terrible week. Or no, let me give a different example. So typical performance is they get the Sunday scaries and they just like, but they get to work. And then the next time they come in and they say, I had such a good weekend. I went on a date, or I went and saw my family, or I did this wonderful thing, and I went to work and there was nothing happened. That's an example of maximum performance. Under these conditions, I can perform the best I possibly can, but typically I'm usually like this. There's all kinds of other examples of this, like, somebody shows up for an intelligence test and they've been microdosing mushrooms, and so they perform better at their best possible performance. It's a dumb example because I don't know if that's even a thing. But typical performance is they're usually exhausted and tired and burned out, and they wouldn't do as well most days, right? So, or they had like 5 Red Bulls, we'll say that. Those are just some examples of that. I don't know how. I'm sure we could come up some more, and feel free to do that yourself. But I'm struggling to come up with relevant examples that are important for the treatment process. Verbal versus nonverbal testing. You may, specifically if you work with clients on the ASD spectrum, you may encounter people who are nonverbal, and you may choose to use a picture test instead of a verbal test. You might encounter people who don't speak English, and you might use a nonverbal test there. You might work with very young children who don't read, and so you can't hold up a card that has a word on it. You have to use pictures, in which case you just hold up the card and you don't repeat anything to them sometimes. So I don't really know how that fits in terms of examples that are relevant here, but there's just explains different methods of testing. There are objective and subjective tests. I'm just going to kind of leave that one just for the sake of time. I don't know there's much important things I need to say about that. In terms of terminology, I mentioned the assessment, testing, evaluation, appraisals, how it's kind of words I'm using synonymously. For tests specifically, here are a bunch of words that kind of get used interchangeably. And anybody who works in test development or does testing for their job, they might look at this and be like, those are very different things. But for our purposes, a lot of times we're really talking about like diction or jargon that fits within the assessment world, at roughly the same stuff. Inventories, questionnaires, surveys, checklists, schedules, projective techniques, screens, batteries, scales, all of these are sort of in that realm of the testing world. So if you hear these, you can go look up the differences, but a lot of these are relatively the same. The one I will mention you'll hear maybe more often is batteries. batteries is a grouping of questionnaires, of testing instruments, of checklist. A schedule is kind of a similar thing of like, we do this test and then this test and this test in this order in order to find out these kind of things, something like that. Number 8 is setting matters. If you are trying to work with, if I were a professor, turns out I am a professor, so it's an easy example. If I'm giving you a test and I have the final exam in paper, in person, where you come on campus, and on that day there's a whole bunch of hustle and bustle outside in the hallway, it maybe isn't the best setting for you to concentrate. If you have ADHD and you use testing accommodations and you go into a room that has a ticking clock, for those of you that have this, you know how frustrating this is or how impossible it is to function with a ticking clock in the background or like water dripping or something. It just like steals your attention away every time it happens and you can't focus on something. The setting matters, and it's important to make sure people are in a setting where you get accurate results, right? If I got a clock in the testing room, I'm not going to see a person's best performance. I'm not going to see what they can do, what they know. So it's not doing what it's supposed to be doing. So, and then paper, pencil versus computer. This feels antiquated post-COVID, but many instruments have been translated to digital format. Some of them you have to buy. A lot of them you can find in PDF form, but even the ones that used to come in little kits, and I'll show you a bunch of these kits in class, a lot of those have been moved online to online platforms too. So I used to work with, I think it was PAR, and get access to specific tests. It just was like a really difficult to like give students access to it and then give them administrations to these tests. And that whole process became too distracting, and students just said like, let's just not do that because it was so hard to make it function. We could have spent our time doing other things. So we're not going to do any of those computer tests, but you totally can get trained on how to do that. And I can show you where to go to do that. In terms of observation, I've been talking now for like an hour and a half. I need to put on some chapstick. Excuse me. In terms of observation, we've done a bunch of discussion. Well, so far we've talked, I think, quite a bit about observation, and this will continue to be a central focus of the class of what kind of things am I looking for. One of the processes that we'll learn later on towards the midpoint of the class is the mini mental status exam. And essentially what we're doing is we're informally looking for behavioral observations of client presentation. Okay, so essentially it's a snapshot in a small period of time of what am I seeing from the client? How are they presenting to me? I'll leave that kind of there. We'll talk more about that in the coming weeks. So I won't say much more about that right now. Observation is also used to make diagnoses. Of course, client report is different than what we're seeing, but also we use our observation. If a client says, I'm feeling just really down, and you're like, yeah, it smells like you haven't showered in a few days, and it looks like you barely got out of your pajamas, maybe, those are observations that are important, and they can reflect back to clients of what they may be not aware of or whatever too. So observation is one of our critical, I don't want to call it a skill set, but it kind of is, but it's also just one of our best tools. Our tools as counselors, we have a lot of them, but it's what we know and what our experience tells us. It's what we see and what we get through our senses. And it's also our emotional reactions to clients too. If I'm getting a reaction of fear and scaredness, maybe this client is using their own anger to overwhelm, or not intentionally probably, but using their anger as a coping strategy for something they're dealing with, and we're picking up on it because we're scared, right? And we can say like, this is, when you do that kind of stuff, it freaks me out a little bit. Is that what you're trying to do? And then it brings up these conversations, or it can anyway. Now, just a quick note about the book. The book does bring up lots of sort of scientific and formal methods. And when you go through there, if you're really interested in learning assessment from that perspective, then you'll get more of that out of the book. I tend to focus more on where I think the majority of students are going in terms of their clinical work, and focusing on informal methods. But the book will teach you other kinds of things too. So if you're If you're wondering why I'm doing what I'm doing, part of it is intentional. We only have so much time to teach these things. The one thing I will say about that is that if you decide you want to get into test development, or you want to learn more formal methods, or you want to get really trained and experienced in tests that we are frankly just not going to be covering in the class, or you may hear me say we're not qualified to do those, you can go do that and learn that additional training. And because you'll be specialized in it, there is so much of a need for people to do assessments these days that a lot of counselors get out and they say, well, I'm going to do therapy, but I'm going to avoid assessment. And that's a really a missed opportunity to, one, make money in counseling. You can often charge for assessments. Psychologists charge like between $500 and $800, sometimes $1,000 usually, for a neuropsych evaluation. As counselors, you probably can't perform that, but you can do other kinds of assessments where you can charge higher rates. So I'll leave that there for now. There's an ethical conversation to be had, especially a conversation about diversity and who can afford those things and what access it grants you to services and that kind of stuff. So let's have that in class if you want to. But it's a way to make money, but it's also a way to give clients a service that they may not have access to if you're not available or willing to engage in it. So with that said, you'll be able to do something unique and special, and you'll be a valuable asset to the community around you, not just the clients, but the other counselors who won't do these kind of things. So use the book, learn the things, practice the methods, become specialized, and this is one way that you can do that. The last one, formal observation, is great for cognitive and or behaviorally focused counselors. Those kinds of observations, part of the reason why cognitive and behavioral, specifically behavioral theories started early on, is that this really heavily scientifically focused, what can I observe? I mean, I can't tell what a person's emotions are. They can tell me, but how do they know? Sometimes we get it wrong. So the only thing we really can be confident about as an observer is the behaviors. And so there was this real big emphasis on behaviors early in counseling and psychology and treatment, whatever. And so it continues to this day to be, what can I see? What can I hear? What can I trust with my senses? It's not so much focused on the intuitions and that kind of stuff. Although now we're sort of changing a little bit in our understanding of counselor as the tool, but nevertheless, it's very, very important. If you see yourself as doing cognitive behavioral work, you'll do a lot of this observation. So good on you. One way of doing that, whether you're doing CBT work or anything else, is using rating scales. And I wouldn't define myself as like a cognitive or behavioral therapist. Usually I'm sort of more emotion focused, existential, humanistic, kind of person-centered sort of amalgamation of all those things. But I do love to use rating scales because it can help clients give better information to me. Rating scales is just like on a scale of 1 to 10, and then you make up your own question. They can be deceitfully simple, but they also can really gather really poignant and pointed information in a really special way. I often use them creatively on the fly. Here's a few examples. Like someone comes in and says, like, I get this panic feeling on Sunday night before I go to work, to stretch out that analogy or that example. And I say, how bad is it? Is it like 1 to 10? 10 is like, I think I am having a heart attack. I need to go to the hospital. And 1 being, I don't feel it at all. 5, sometimes I'll put in a 5 definition so they can kind of gauge it. Like 5 being, I'm probably not going to go to work, but because I'm too ill to function, so whatever the scale is I want to make up at the time, just so we can put some common language so they know how to respond to me, so they feel heard, so that I understand what they're talking about. It's that kind of thing. Another example is the other one here. You can read that one, but or I'll read it to you. When your husband says that to you, how close do you feel to that person? 1 being, I want a divorce. 10 being, we have the best marriage possible and I want to be close to them right now. And I want a big hug and, let's be intimate together, whatever the thing is. You make up these things on the fly and you can get a lot of good information. You can also frame things for clients when they say like 10, this is the worst pain ever. And you're like, oh, okay. Well, what about last week when you told me when when you experience this other thing and that was a 10, this one doesn't seem quite as difficult for you. You're functioning better. So what's the difference? And you can help them sort of tease out a little bit too using these kind of things. And then collateral sources, there's not a whole ton to say right now, but maybe this is worth more of a conversation in class of, I went through these personal, professional sources and records. It's what kind of information do you have access to? One of the things that I do in some classes is I'll say, like, what information is missing? What other information would I need in order to make a diagnosis or something like that based on a scenario we're talking about? And oftentimes we'll have school counselors say, well, I'd really love to know what the parents think. I'd love to know what the teachers think. And mental health counselors say, I'd really love to know what the spouse who is sitting in the lobby thinks, and like all these other collateral sources. And yet oftentimes we just don't have the luxury of that kind of access. Sometimes we do. And how do we get that? Through getting a release of information, through, all, like, there's a process for that. You can get really good information. What do you do when you don't? That's something we'll continually practice and talk about. Depending on your setting, you might have more information than other places. I know one question that comes up in internships sometimes, and not debates, but like discussions I've had with people in the past is, do you like to go into a session unbiased and blind? Even if you have access to records, you don't read them because you want to hear from the client specifically first and make your own judgments. Then you go back to the records and see what they say. Or are you the kind of person that likes to go in and be informed before you go in, so you kind of know what you're getting into? There's no right or wrong way. There's no better than others or whatever. It's kind of a comfort zone sort of thing, and how you practice your best. So how you use those collateral sources is kind of up to your discretion, sort of, and your site and supervision and all that stuff. Okay, here's our last slide. This is where we talk about diversity. Let's see, where do we start? So counseling and assessment has a tenuous history in terms of diversity and how it has been used. I'll give you two perspectives. There have been, I don't want to go into them specifically now, but there have been certain client populations, African Americans, used in research and development of drugs, and using tests to do scientific inquiry on certain groups has caused a bunch of distrust in those groups. Another one is my disability community. Let me actually add to that first before I go into the disability community. One of the things that does is it creates distrust with this structure of power. These people who are in power positions, they're using this information in this testing process to continually disadvantage me and systematically disadvantage me. That doesn't really do what we're intending to do, which is create empowerment and self-advocacy and therapeutic alliance, which relies on trust, right? And therapeutic benefit and helping people become more well. Since we're counselors and we follow this wellness model, like if we're using assessment and it's not fulfilling that obligation to do what's in the best interest of the client, not a good situation, right? And so historically that has happened, and it's caused a lot of distrust, sometimes in the profession and sometimes just in the results of data, frankly, and how it gets used. I think there's probably still a conversation to be had about how that still happens today. Most salient to me in terms of race relations and that kind of thing is we as a program don't require the GRE anymore. And several years ago, maybe 5 years ago or so, a lot of programs kind of all en masse decided the GRE was actually more of a reflection of race and class than it was of intelligence. In other words, the people who lived in suburbs, who could afford tutors, who more funding went to because they perform better, and No Child Left Behind legislation, because of legislation like that. And I don't want to get into political conversation, but here's the story that I was told. If you perform better, you get more funding. And so the better performance got more funding. The people who weren't performing better got less funding. And that eventually stratified like the urban, largely African-American communities. And then when they get to college, they take these GRE tests and say, oh, you're underperforming. You're not likely to graduate school, so we're not going to let you in, which further disadvantages people. So the GRE kind of went away. It's not fully away. It still gets used, and there's really good benefits to it too. So I'm not throwing the baby out with the bathwater here, but that's a diversity concern, right? So that builds distrust in the assessment tools and the process. My disability community, assessments were often used to send people away to mental hospitals um, to literally perform castrations or sometimes chemical castration, so people couldn't have babies if they were assessed to be mentally incompetent. Like that's all part of the history of America, of people, and that's been happening not just in America but around the world in different ways. And so there's just a lot there. So I'm not going to go into more examples, but let's do talk about it. Let's have that conversation. I think I've already kind of talked, sort of opened up the door for discussions of privilege and fairness. I'll define these words edic and emic. If take a look at me. I'm white, I'm middle class. You don't know this, but I'm heterosexual, or maybe heard me talk about my wife. I am, what else? I'm middle-aged. I'm like the stereotype of privilege, and I can't really help it. I was just born this way, right? If I go into some other, let's say I grew up in a rural community, let's say I go into like urban Chicago and I say, I'm here to help. I'm a white savior here to make things all kinds of better. Tell me your information. Tell me what it's like to live here. And I'm essentially an outsider. I don't really know what it's like to live in the experience of that culture, of that place, of those people, that kind of stuff. That's the difference between edic and emic. In one case, you're an outsider. Another case, you really understand it from the lived experience of being that kind of person, of holding that kind of identity. Now, I don't want to get too much into this, but one thing counselors are often concerned with is, how can I understand a woman if I've never been one? How can I understand the experience of somebody who's lost a child in pregnancy if I've never lost one? How can I understand what it's like to be an addict or a vet or have schizophrenia or any of these other things? How can I be trusted as a counselor? And the answer is, I don't know. But yet healing still seems to happen. And the health benefits of counseling still seem to happen if a person is open to learning about other people, is open to understanding and I'll use a big word here, phenomenological experience, just means the way I see it through the world. If I'm open to learning from other people and hearing them and validating them and giving voice to their story, people can get better. So whether I fully understand it from my own experience as an insider in that group, or whether I'm an outsider willing to spend time to learn, there's not necessarily one better or worse way, but it's definitely a conversation to be had of, am I asking questions? Am I using the assessment? Am I assessing accurately from this arrogant power perspective of, I know what I need to know because I know what's good for you, which doesn't really work, right? So, and then there's biases all over the place, and we can talk about those. Biases to me are not people that I don't like, people that I disagree with, which we kind of use that term that way, but it's also things I don't understand about people that seem confusing or uncomfortable or something like that. Like, we wouldn't really call it a bias for me to talk about somebody's menopause or how they're hormonal because of their monthly menstruation cycle or whatever. Like, I don't know what that's like, but I have a bias against it if I'm ignorant of what that experience is like. And I know that's something we can talk about more too. But I will just make mistakes because I don't get it. And that doesn't mean I can't learn though and understand what it's like for people that want to discuss that. So anyway, assimilation and acculturation. Within groups, there are people who learn to live in the society as within the identity of the culture that they're living in, or people who maintain their cultural identity at different ways and different styles, right? And that process of how much people are expected to do that, and how much are they allowed to have their identity of birth or geographical origin or whatever, it's just a whole nother big conversation. In terms of assessment and testing, am I testing them in a way that fits my culture, or their culture or some blend in between. That's the conversation to be had. Of course, labeling, categorizing, and stereotyping. I would love to have a conversation if we haven't done it already. Maybe we do it during this upcoming class about what's the benefit and the detriment of a label. On one hand, I feel sick. I don't understand it. Nobody understands me around me. And I go to the doctor and they say, oh, you have this condition and there's treatments for it. And there's a community of people that also have this and there's ways of understanding it. And I'm like, oh, finally put a name to this thing. That's wonderful. But then there's a dark side too. And the dark side is, don't you dare call me that. You don't have the right to call me that. One that comes to mind is the word that we're kind of moving away from now, thankfully. But for a while, it was the scientific community said mental retardation is a condition where basically you have an IQ of below 70. And it was just the name for, just like we use cancer or diabetes. It was just mental retardation was just the thing that you had, and it wasn't a big deal. And then it started to be used to disadvantage people. And then pop culture decided to start calling everybody retards. And then it was like, but that's not, it's used in a derogatory way, and that's not okay. So labeling can be a really helpful thing, and it can also be a really harmful thing. And how we use that is a part of what we're training and learning, training to be able to do and learn here, because we have this power and we need to use it appropriately. Categorizing and stereotyping, same thing. Let's talk about them. Let's have more conversation. Testing accommodations, we're unfortunately not going to be able to go into that whole ton. But accommodations are like, if you don't speak English, you need a Spanish version of this assessment. Great, let's make one. If you don't have hearing, let's bring an interpreter to the evaluation that we're giving. There's all kinds of ways that these things can be accommodated that we'll talk about some through. I gave the example of testing in a room with a ticking clock. We just take the clock out. It's not necessary. You know what I mean? Like, we'll use a digital clock or something. We can accommodate this to equalize the experience. In other words, if somebody is disadvantaged by a certain condition, like not knowing English or not having the same sound capabilities as other, normative standards, we can get this person up to testing at the same level. It's not to give them advantage, it's to provide equality. It's an important distinction. We will, as we go into this, we'll talk a little bit more about if you're, depending on what kind of testing you're going to be doing, specifically how we can do that. And a lot of formal testing manuals will give you instructions on how to perform accommodation, stuff like that. I'll tell you a story later too about an interpreter who went along with to an intelligence psychological eval during an intelligence test, and there was an issue there. I'll tell you that story when we get to that chapter. Testing specific populations. Some of you may want to specialize in some of these things: ADHD, autism, personality disorders, testing in certain communities of certain demographics, that kind of thing. That's where I will never be able to give you enough information about that specifically, but I'm shaping the class in a way that lets you develop this skill set on your own with my assistance, and then you'll get more supervision later to make you the expert that I will never be. So you'll have that opportunity to kind of build some of that specialty from the get-go. And then I guess I wanted to have a smiley face in here, and more to come on assessment bias in future units. So we'll just leave it there. That's pretty much the end of it. So thank you for sticking it out with me to the end of this. And I, again, will see you in class when I see you. Bye.